Welcome to Bipolar She. I'm your host, Janine Noel. Before we get started, the content of this show does include suicide and suicidal ideation. If you are ever in need of immediate support, please dial 988 Suicide and Crisis Lifeline. I believe in the healing power of writing and speaking our mental health stories in all their raw details. So let's go. The following is a two-part episode with my guest, Dr. Susan Swick. Dr. Swick is a clinical psychiatrist and the director of Ohana, a Center for Child and Adolescent Behavioral Health at the Community Hospital in Monterey, California. Ohana is just 1 year old, and they are already tracking good results from their innovative approach to children's mental health. In the first episode, we learn of Dr. Swick's personal connection to mental illness and how Ohana is grounded in the breakthrough idea that mental illness is always treatable, can often be prevented, and that mental fitness can be developed in our youth. We discuss a new type of family-centered therapy and what bipolar disorder may look like in a child. In part 2, we learn more specifically about this new therapy, the dialogic method. Welcome, Dr. Swick. I know you're really busy, so thank you so much for coming on the show.
Oh, I'm delighted.
Yeah, so I'd love to start just how we talked about an experience with a family member that had mental health issues. And I'm curious about that story in your life.
When I was a fourth-year student in medical school, actually, so let's see, that would make me 28 years old, thereabouts, it became clear that my mom had been dealing with a psychotic illness that was episodic and some mood and anxiety symptoms also. I have a sister who's just a year and a half younger than me. We're very close. And my mom is an extraordinary person. She's a preschool teacher who had put herself through college and grad school to pursue a career in early childhood education. Such a loving, committed, wonderful mom. And very focused on early childhood. So always made activities for us to do. We made our own Halloween costumes every year. She was well known to all the kids in the neighborhood, but she would have periods as we were in adolescence during which she felt targeted. So it started maybe when my parents got a divorce, which made some sense. That happens in divorce. And these periods wouldn't last too long. But then when I was a fourth year in medical school, she became frankly psychotic. She showed up at my sister's home feeling like she was being persecuted and she needed protection. And so while I was training and while my sister was raising her family and while I was eventually raising my family, we would have these episodes that would come unpredictably, last weeks to months, in which we needed to sort of drop everything and show up for her. And I felt like I was getting trained in cutting edge, really effective treatments. And then on my own time, really working to piece together scraps that would get my mom adequate care. It was so meaningful to me to have a sense of how critical the family is in care, even for adult patients or geriatric patients, but not just that it's humane to make sure the family is at the table and connected, that it has to be centered on the patient, but trying to find a way that also expands on the love and connection that's there within a family, because that's great raw material for healing and health. And I suspect it has had a very profound impact on the way I approach mental health work, but thinking about how it coalesced to form some of the ideas I have about the power of including a family in care, especially with younger children, and maybe in particular, the power of building mental health, building mental fitness, not just conceptualizing mental health as the absence of illness, but addressing symptoms when you must, conceptualizing them as an illness if that helps to effectively address the symptoms, but also paying close attention to who this person is. How are we thoughtfully expanding their health and well-being? Because those skills are actually going to be active and critically important if they do have symptoms in the future, if their symptoms get worse, but also just to build a life of dignity and meaning. So over the last 20 plus years that I've been training in child psychiatry in particular, that is foundational to the way that I've come to think about the bigger picture, not just a cure for schizophrenia, psychotic illnesses of midlife, which could have been a very natural area of interest for me, but instead thinking about how building blocks of mental health that we establish, particularly in youth, but it's never too late, we can always build them later on, are critical sort of to our psychological immune system and our capacity to weather mild difficulty, moderate challenges, or really intense adversity, and how we build those skills over life. And it can overlap sometimes with symptoms, illness, and treating illness, but how we build those skills. And it's really tethered to an empowered idea that we all have within us a capacity to sort of expand our muscles, our psychological immune system, but also our mental fitness, so that we're better and better equipped to delight in the wonder, awe, and joys of life, even in the midst of adversity, and to manage the adversity itself.
Yeah, I find it very interesting now that you're doing this innovative work down at Ohana and trying to give that resiliency to children and adolescents, young adults. I'd love to just learn a little bit more about how those programs work. Yeah. And I may say this incorrectly. The dialogic method?
Yeah.
That is?
Yeah.
Okay. Yeah.
Good job. You said it just right.
Okay.
So Ohana is a wonderful child, adolescent, and family mental health center. It's a part of a community. And when the local donor, this wonderful philanthropist that's lived here for 50 years, decided to give the hospital $100 million to create this mental health center. And we really thought carefully about how could we, this is a big gift, but it's a limited gift. And, given the current landscape of mental health services and needs in young people, it'd be very easy for the gift to not really move the needle for many families. We could use that money to build sort of locked inpatient hospital units so that when kids were in crisis in the ER, they'd have a place to go. That would have probably chewed up the whole gift. And the problem with that would have been that we might stabilize young people in a mental health crisis, but then they'd have no place to step down to get effective treatment that actually should be curative. And so, I came to this project with a public health background as well as a clinical background, and was really interested in the idea that a community hospital should make it very easy for parents, pediatricians, or teachers who are worried about a child to refer them to get a high quality evaluation that'll illuminate if this is a normal developmental challenge, maybe some learning difficulties that hadn't been identified, or if there was an emerging psychiatric illness. And partly because psychiatric illnesses are incredibly common in childhood. They are not rare. They affect somewhere between 20 and 25% of kids before they turn 18. That's at least twice as common as asthma, which we often think of as a common childhood illness. They've also become more common in the last couple of decades. The rate of anxiety and mood disorders specifically has climbed among 12 to 24-year-olds by as much as 50%, given different surveys. It's not climbing in those over 24. So it's really interesting. There seems to be something happening in the population of young people. And then we also know, and we've known this for a long time, that psychiatric illnesses are, generally speaking, illnesses of youth, right? So 50% of them have shown up by the time a child turns 15. That means all lifetime psychiatric illness. So my mom is the exception to show up in her 50s. 75% of all lifetime psychiatric illness has shown up by the age of 25. And that mid-20s age is a really critical number because we now know that from a brain development perspective, that is when youth is wrapping up. We think of it as 18 because that's the legal age. But actually, from a neurodevelopmental perspective, we've really learned in the last couple of decades that the rapid pruning, myelinating, renovation that happens in the brain during adolescence is wrapping up right around 25. So these are illnesses of youth. So if you can catch them when they first emerge, they're much easier to treat. We have learned a lot about treating these illnesses and what evidence-based treatments can be effective in the last 4 decades, so that now every illness that emerges is treatable. What's really fascinating, and many people, even within mental health care, don't know this, most are curable. We can treat them effectively into remission and be able to stop treatment and have them remain in remission, right? Which is sort of the medical definition of cure. And we also have learned quite a bit about them being preventable, that if you can do targeted interventions with children at risk, often we can do targeted interventions to the parents. And just equipping the parents with certain skills can make the protective difference. It can work like a vaccination for those children. If you know about a particular sort of targeted vulnerability. So, kids who have a first-degree relative with a mood or anxiety or thought disorder. So maybe when I was a kid, we know that there's interventions you can do directly with that child or with their parents that can create some skills that will protect them like a vaccine against that particular risk from materializing into an illness. So if you have a higher likelihood of having a mood disorder, it protects you. And then we've learned, in addition, about some of the practices that are universally protective. They universally can protect children from having mood disorders, anxiety disorders, substance use disorders, and eating disorders emerge. And those skills actually are pretty foundational to my thinking about how do we build mental fitness. So that in the same way that if we want to protect against heart disease, if I have a family history of a genetic problem that confers risk for heart disease, I'm probably going to grow up thinking it's extra important. My parents are going to tell me it's extra important for you to have regular exercise, eat healthy foods, and keep your BMI down in the safe range. Get restful sleep every night. And then we have sort of screening medical appointments, maybe once a year. But those habits, those healthy habits also are how we build general physical fitness, right? So that I'm not just protected against the heart disease I may have risk for, I also am equipped to recover more quickly if I get a flu or another infectious disease, or if I break a bone or have to have surgery. My recovery time is better if I went into it in better physical shape with the healthy BMI, regular exercise, and good sleep patterns. So in the same way, we've been paying really close attention to what are the skills, sort of the personal health habits, as well as the stress management skills, the self-awareness skills, the social skills that equip us as adults to be more mentally fit, to be able to manage adversity, whether it is the symptoms of a mental illness, it's a divorce, it's a change in work, it's a move, it's even a positive change, having a child, getting married. Those changes we think of as joyful changes, but they're extremely stressful and they're difficult for people. Transitions are very hard. So being equipped to be able to manage transitions, to get your balance back quicker, to adapt quicker, to still be able to experience even small amounts of delight and joy, awe, humor, even in the midst of managing a challenge. That is sort of the essence of being mentally fit, of having good psychological immune system. So we thought about designing a full system of care, but that also feels like a wonderful resource for the whole community, introducing this idea that mental health must be built. And mental illness is common and it's very treatable. In fact, it's usually curable if you get the diagnosis right and you get to evidence-based care. But mental health has to be built. It's not the absence of illness. We now have a campus. Our campus opened a year ago, and we have a team of a little over 100 people who both provide diagnostic evaluations, treatments at different levels of intensity, depending on the nature of the problem a young person is facing. That really does two other things that are not as common in youth mental health care. It brings the family into treatment. We don't just leave families out in the waiting room or in the parking lot. We, of course, respect the privacy and the autonomy of the child, especially as they get older. But we recognize also that we're social creatures, we are connected, and that families are often a critical and central part of a child's life. And how are we equipping the system around that child to accelerate what they're doing, to complement and empower and improve what that child is doing, or to be able to bear right alongside that child the challenge or the difficulty of building those muscles, because sometimes it's painful. And the other piece we do is we integrate this idea of mental fitness into treatment, into diagnostic evaluations, as well as different levels of care treatment. And we have a team that goes out into the community to help schools, parents, faith communities, and others be sophisticated in thinking about how are we building mental health for ourselves, but particularly for our young people, and helping them to do it so that it's an empowered community. Maybe one that over the next decade or so will actually bend the curve. So the curve of mental illness in youth that was going up that I told you about for the last 2 decades. And the good news is what goes up usually can come down. So if we can actually bend that curve and learn about what works really effectively and efficiently at actually building your immune system so that you can face change, challenge, and adversity and flourish nonetheless.
So I know you have resources for children, adolescents, even young adults.
Mm-hmm.
So with my bipolar disorder, my first incident was when I was 20 and then when I was 25.
Mm-hmm.
And at that point, this is 90s, early 2000s, there really wasn't any treatment like this that would ever bring in the family to do work.
Right.
So I guess I'm curious, like, were there symptoms or signs in me that could have been picked up earlier? And so with a bipolar child or adolescent, I'm curious what you're looking for and how you even diagnose that.
That's a great question. I mean, one thing you made me just think of too is that we call the years from 18 to 25 transitional age youth. Our shrinky terms are terrible. It's young adulthood, but it's a critical moment because, like I was saying before, it's still developmentally youth. From a brain perspective, it's still youth. From a legal perspective, though, we're adults starting at 18. So it's such a vulnerable time to have illnesses emerge. And illnesses like bipolar disorder, schizophrenia, substance use disorders, and to some degree, major depression primarily emerge in those years, 18 to 25. And it's so complicated. The patients are young people who are legally independent, but still would benefit from support. And so finding a way to respect their autonomy, their independence, and to be able to reasonably lean on the support of a family system. It's made harder by our healthcare system doesn't make it easy because you can't legally communicate. So those things become very complicated. And you're right, mostly with bipolar disorder in particular, there is pretty good evidence that there often have been symptoms of maybe full-blown depression or subsyndromal depression. It's usually not mania or manic episodes. There's a very well-known set of studies that demonstrated that young people who've had an episode of a major depressive illness before puberty, 50% of those kids will go on to have full bipolar disorder. So good child psychiatrists know that when they're trying to treat like true depression, and this is where it's so important to have a good youth mental health system, because sadness in children is actually common. It's developmentally normal. And being able to stay alongside a child and not over-pathologize them if they are feeling understandably distressed at the loss of a loved one, at a big family move, if they're struggling to adapt. But true major depressive episodes before puberty, as often as not, and a little more often than not, predict bipolar disorder. So thoughtful child psychiatrists will actually pay attention to being more careful with medications so as not to actually stoke the possibility of having a manic episode, which certain antidepressants can do. And when you have a prevention mindset, there are wonderful studies that have come out of UCLA that have demonstrated that being able to have really disciplined approach to being protective of sleep and sort of regular biorhythms, so sleep and when you eat, can be very protective against an episode of mania ever emerging. So it's a bit of a murky answer to your question. So I don't know if you had mood symptoms, and depression can sometimes masquerade in really smart young people. They can internalize those symptoms because they don't want to burden their loved ones. But sometimes when you poke around, you discover that actually there really were symptoms of a depression, and we might have been able to protect healthy development and minimize disruption by maybe stabilizing the mood problems with a medicine that's not going to precipitate mania, which some of our antidepressants do, and probably just as important, maybe more, helping the child and the family establish habits around sleep, exercise, managing the rhythms of life, essentially, but in a way that's quite structured and regular, but it can be very protective.
Please consider Bipolar She a work of advocacy, getting important stories to those who need them. Please like us and rate us and leave us a review wherever you find your podcasts, and especially on Apple Podcasts. Find us online at bipolarshe.com or at bipolarshepod on Instagram. And thank you, as always, for your support.